Thank you. Thank you. Thank you, Rafael. Good morning, everybody, and thank you for the kind introduction and invitation for me to speak. Um, uh, we met at ATS last year after the symposium that I chaired, and I'm so really excited to be here. Time passed by pretty quickly. It's already January, and we met in May. But I'm really excited to be able to talk, and I'm really honored to be here to talk about some of the older things and then new things for asthma management 2024. Okay, so let's see. I hope the flower is not in your way. I just wanted we needed a little bit more pump and a feeling of the spring because we just talked about how miserable our weather is right now. So right, there we go. So I do receive advisory board fee from AstraZeneca and grants from these organizations, but it's nothing really pertinent to this presentation. So I'm going to start with a case. So I have two cases here that I'm going to come back later. So if you just put that in the back of your mind and then think about it, because we're going to talk about it later in the talk after we go through everything. So this is a 50-year-old female with asthma. She has symptoms every day, wakes up at night a couple of times a week, can't do exercise because she has shortness of breath. Had asthma attack 3 months ago as an outpatient. She has prescribed daily controller inhaler, but says she's using it most of the time, but she forgets sometimes. There's another 50-year-old, same age, female, a little bit more milder symptoms a few times a week in a bad week, which she has about a couple of times a month, doesn't wake up at night, can't do exercise. And then her asthma attack was about a year ago, and she also has prescribed daily control and medication, but she's not really taking it anymore. So I'm going to come back to this at the very end of the talk here. So we have a lot to talk about per request here. So and then it kind of go a little bit diffuse and broad. So I just wanted to orient you on what we're actually going to talk about. So I'm going to touch about a little bit about difficult to treat asthma, which is not new, about initial evaluation and about comorbidity. And then switch gears and then talk about this hot topic, which is relatively new in the asthma field, about as needed in use of inhaled corticosteroid in mild asthma and then in moderate severe asthma. And then a little bit about the new data, practical thoughts, but sorry, I won't be talking anything about biologics here, and hopefully some other speaker will talk about this, and you probably have heard it from multiple other speakers. Okay. And then again, I'm just gonna use the GINA guideline to orient you a little bit as well too. I'm sure many of you have seen this rather complex guideline at least at one point in time, or in the versions they've been gone through. But I'm using this just to orient you on what we're actually going to talk about. So I'm going to talk about first about the comorbidities assessment with this the management cycle that I have that sometimes people don't pay attention to on up here. And then switch gears and then talk about as needed therapy, where is on here on this track 1 and track 2 for step 1 and 2. And then a little bit about the SMART therapy for step 3 to 5. And then just a little bit about updates on this new added as needed ICS SABA reliever. So I just close up that circle that is on the top of the guideline here. It's called the asthma management cycle. I kind of like this. It's often forgotten because it's right on the top of that table here. but I do use that in my clinic, especially to talk to the fellows and the residents about how we should actually do the asthma management, especially for difficult to control asthma patients, what we're going to talk about. So how GINA recommends is that we should do take care of the patients with a cycle here with assessment and then adjusting and then the review and then keep going. And then today we're going to mainly talk about the initial assessment here about confirmation of diagnosis, symptom control, and modifiable risk factor, identification of comorbidities, inhaler technique, and then patient preference and goal. And then you treat the treatable traits that you identify and then review it again and then come back and keep doing it. So difficult to treat asthma is there. You all probably have seen it. And this is a data from the Dutch population from the survey who with adults for 18 years old with asthma. And if you look at everybody with asthma, majority of them are actually not on a high dose ICS/LABA treatment, step 4 and 5 treatment, and majority of them actually, we're going to go into the mild asthma when we're talking about as-needed therapy, but majority of them is mild to moderate asthma here too. But 24% is step 4 to 5, and then within that 24%, 17% is what we define as difficult to treat asthma, because basically the definition for that is that despite on high dose ICS/LABA treatment, step 4 and 5 treatment, but then their control is still poor. And then the true sort of definition for asthma is that if, after you did all of the other, like the adherence and inhaler technique, there's about 3.7% actually left that we define as severe asthma. So poll, I didn't make the fancy sort of an app poll here, so you can just put, but I wanted to make it interactive so that you can stay awake here. So I'm just have two polls in there too that you can actually just put your question, you put your answer in your chat box. So the question is, I have a way to assess comorbidities and risk factors for difficult to treat asthma patients and do it in the same way for each patient. Yes for one, 2 for no, and others, if you have anything, type in the chat box. Chat box is enabled, right? Okay, right, just making sure. Sometimes it's not. Yes.
Enable.
Can you, yeah, just so if you guys can just put 1 or 2 or yes or no or other, just type it in there. Just kind of wanted to see it. If you can have the type. I'm just waiting for a few minutes. Well, I just saw Rafael, but I don't see anybody. But anybody, if you just participate, that will be fine too if you can. Well, okay. All right. I have another poll too, so I wanted you to participate in that if you can. Okay. So I'm assuming some people will say yes and some people will say no, but I think my guess will be that maybe a lot of people may say yes, but maybe you could have something that is protocolized per institution, or you have a no template, or you probably have a way, your own way, or somebody else's way that you actually follow. That's actually my guess here. So that brings me to talk about the systematic assessment especially for the initial evaluation of difficult to treat asthma. So there's multiple published protocols out there that individually been tested as a process and see if that works. And then and on those, it's pretty much before and after type sort of a studies mainly, but they have shown that improved outcome, especially to improve the difficult to treat asthma patients' outcome in a subsequent visit after you follow the systematic assessment and treatment. And in one of the review articles in JACI IP from Hugh, basically they talk that there are mainly 3 broad domains, which I agree that is basically going through asthma itself, comorbidities, and patient factor, which I'm going to review it in the subsequent slides. The templates can be developed by the caring team based on local needs and resources. And it's very important to do it systematically because there are a lot to go through for these patients. So the asthma domain, just going to go through briefly because each and single one of them, I can be spending an hour about all of them. But we need to assess the diagnosis, impact and burden, which is exacerbation and asthma control, their triggers, and then phenotyping. I know this is really big in the field as well, too. I am not going to talk about the phenotyping today, but the phenotyping will consist of eosinophilic, non-eosinophilic, late onset, early onset, allergic, non-allergic. There's other phenotyping that could use the biomarkers like the blood test or FeNO. And just a few words about the diagnosis, because I know the diagnosis talk is upcoming, and it's really exciting that you all are going to hear that talk as well too. But there's issue with overdiagnosis and underdiagnosis, and data have been showing up to 12% of the specialist referred patients have alternative diagnosis other than asthma, which I think I agree in my practice as well too. So confirming a diagnosis is quite important. Before going to the comorbidities, going to touch again briefly about patient factors because again each of these we can spend hours talking about it, but inhaler technique view is very important to have it protocolized as well and put it in as a routine service to the patients because high percentage of misuse is present. Adherence, I'm going to touch about this in my later slide when we talk about as needed ICS, but adherence is about 50% overall in asthma patients, so it's important to have an objective way to measure this and give feedback to the patient as much as possible. Self-management skills like action plans, discussing about their treatment and self-management skill that's important. And of course, social determinants is really, really big, but I'm not going to go into that today. So this is just not to be exhaustive, but it basically just listed some of the comorbidities that have been associated with the asthma, and the list is very, very long. Starting from the upper airways is rhinosinusitis, inducible laryngeal obstruction, like or vocal cord dysfunction. Other condition affecting the middle airways like reflux, OSA, larger airways, tracheal bronchomalacia, excessive dynamic airway collapse, and then for the lower airways, presence of COPD, bronchiectasis, EGPA, ABPA, and then other diseases that affect in the breathing perception like anxiety, depression, dysfunctional breathing, hyperventilation, obesity, and then of course there's steroid side effects, especially for those who have high steroid burden. And comorbidities are really common. I'm sure everybody in this room have in this lecture has seen all of this, but there are data for how common these are. This is from the WATCH cohort, which came from a tertiary referral center for difficult asthma clinic in the UK, and their way of doing this systematically is that they do it pulmonary and extrapulmonary, and then they divide it to physical and psychophysiological. You can see bronchitis, COPD, ABPA is present about 10% or so. Rhinitis, reflux is a lot more common, and then obviously obesity is very prevalent, and some sensitivity, salicylate and sulfite sensitivity, sleep apnea, and then other psychophysiological disorders as well, including the inducible laryngeal obstruction here. Now, in our own cohort for the CV asthma research program cohort, which we will be presenting at ATS 2024 as part of the longitudinal follow-up data, we have over 240 patients in the CV asthma research program that we followed from SARP-3 to SARP-4, and have biomarker data, their asthma control data. In addition, we do have their comorbidity data as well too. So this is the left column is showing at the time when they got enrolled to SARP-3, which is from 2012 to 2015. And then about 7.8 years later from SARP-4 to that was from 2023 to 2023. This is the same patient that assessed twice in about 8 years apart. You can see obviously that age has increased about 8 years. But then the BMI increased. Every single comorbidity incident has increased. Especially obesity related, like OSA has increased, diabetes has increased. You can see that many of the patients that reporting the comorbidities has increased in about 8 years. And more details for this, and also about their biologics and their biomarker changes, those will be presented at ATS 2024. So the complex situation is that all those comorbidities are not independent to each other, and then it's all connected and sort of mixed in all together. And these authors actually sort of propose this difficult breathing syndrome for these patients, which they define as a multi-morbidity constellation of conditions that contributing and burdening to asthma. I mean, this is a very messy sort of a figure, but I think it actually does tell the reality about many of the patients have this syndrome where the asthma is here, but all these comorbidities and conditions and the social determinants like the occupations and unfit and other things actually going feeding into the lack of quality of life, and then poor control of the asthma as well. So what do we do? I'm just going to come back to the the systematic assessment. So I think it is important to do the systematic assessment, and in a way that will work for each providers and institution. So this is one way of doing it. This is it was done in a pragmatic way, but within the sort of scope of a study that they actually looked at the how impactful the systematic assessment and the treatment is. So this is from Australia, from a tertiary hospital in Melbourne, that they had difficult to treat asthma patients, and then they did a systematic assessment of their condition, and then they actually defined the trait and in a way that they have systematically assessed, and then they did an intervention. For instance, they had this age of onset and employment trait. Now there's no intervention available, but if, for instance, they looked at the smoking, they have the definition, and then they provided smoking cessation counseling. They looked at eosinophilic trait. They looked at whether they have viable airflow obstruction, and then they treat it with medication and biologics, allergic rhinitis with medical management or anti-IgE, rhinosinusitis, medical management, and consolidation of surgery by ENT, vocal cord dysfunction evaluation, and then the speed therapy, and then dysfunction breathing, obesity, anxiety, essentially to referral to the specialist. And what they found is that there are 5 traits with the latent class analysis that they defined, which are allergy dominant type, eosinophilic dominant type, comorbid dominant type, psychological dominant type, and then the multi-domain dominant type. And if we look at sort of the before and after of what happens to them, now it looks like, everybody has improved in 6 months, which is really great. I think that shows that, if we do everything all together, that does improve. But if you look at the little bit of detail on what's happening here, for instance, the eosinophilic people have this profound improvement in exacerbation, maybe from the biologics or maybe from the inhaled steroids that they use, versus there's more improvement of quality of life on the multi-domain people with all these. So you have some subtle difference on how they do, but overall, they seem to have done much better with at least in the scope of pre and post type evaluation here. So this highlights the the effect, and we see that right in real life as well to deal with this comorbidities and the trait in a systematic way. So, but there's issues. It's we already talked about multiple complex interconnected conditions. So then in reality, though, especially in the US, though, we gotta have to decide which one is treatable, modifiable, and then which one we need to address first, because we really can't maybe possibly do everything at the same time. Maybe the resources and multidisciplinary team for every single comorbidities assessment and treatment is not always available. And then, and again, especially, that earlier sort of a way with all the referrals, maybe that can be done in a referral center or somebody who has good insurance, but there's a cost consideration for that, right? Because if we make too many referrals, too many tests, that will be a big bill for the patient. And that can actually feed back into the situation where they won't be coming back to you, or can't afford a medication and go through the vicious cycle as well. So we gotta really have to be thinking about that as well. So I'm coming back to the importance of communication for this portion of the talk, which is not new, especially patients, physician team, patient communication is really important, especially at the initial visit, in establishing the physician and patient relationship, and is really important to do that, increase the chance of non-adherent patient, difficult patient to return, and explaining what you found about the asthma, as well as the other things that feeding into the poor control condition, and what you are going to treat first, and then realistic expectation of the response. I often say that it's really tangled, and it will take several visits to untangle. So, we're going to switch gears now and talk about the as-needed ICS. So this is supposed to be Asthma Management 2024. So we're going to have to talk about something new, which will be the as-needed inhaled corticosteroid use in asthma. That is relatively new and hot. So I'm going to talk about mild asthma and moderate to severe asthma, focused on SMART here. So again, just orient you again too. So we're going to talk about the step 1 and 2, track 1 therapy with formoterol, ICS formoterol, and then SABA as needed. SABA ICS is needed, and then the SMART for the step 3 and step 4 here. Oops. Okay, there's another poll. The lights went off. The poll here, hopefully maybe people can type in here now. I have been using as needed ICS therapy for asthma, either as needed only for SMART, and know how and which patient to do it. And I have been using, or I've been using it in my patients, but having difficulty doing it constantly. But or maybe have no idea what it is, and I'm here to learn about it. Maybe other if you have any other comments about it, please type in the chat box. Maybe if you can spend some time, if you can put in anything, okay, too. I see it too. Having difficulty doing it constantly, I hear that. Anybody else wants to say something for this poll? Well, if you have other comments about it, we will do a Q&A, but so I see two, which I think my guess is will be is a pretty common, most common question answer for everybody. Yeah, I see a lot of twos. So and then if there's other comments about that on the difficulty also, you know, well, I will go over that about the pragmatic and implementation challenges, but you know, be free to put something on there too, because I do like the discussions about this. Yes, and then yes, tried a few times, and then day 2014, yes, and it's difficult, yes. So let's talk about this. So one of the issue is that this is relatively new and not everybody knows about it, especially if you are not a you know, like the asthma pulmonary people as well. So because we have been recommending short-acting beta agonists, albuterol, in this country, used as a reliever to relieve symptoms, plus daily therapy for 30 years. And so that's kind of like what we have been used to for a long time, and that is part of the reason that there's some implementation challenges. So either the albuterol can be used with the maintenance daily medication, like these medication here, but then these are daily, and then the reliever as needed, or basically just albuterol only as needed, and it's been the guideline choice for over 30 decades. But we mentioned a little bit in a difficult to treat asthma about the adherence. So I'm going to go a little bit more into the details. So the general adherence, if you take everybody for asthma patients, about 50%. This is a table here that's showing pediatric studies, but it's basically dating for 1996 to 2015, about 20 years. Of looking at adherence in many different ways from different papers. So you can kind of see in 20 years, nothing has really changed, regardless of many efforts for from the field and all of you, that the average is about 50% for asthma. And there's a fundamental reason, you know, for that as well. So one of the reasons are there's concern for cost and side effects, especially prominent in the minority population. And then, you know, since asthma is episodic disease, timely physician follow-up for maintenance medication adjustment when things are going either well or not well, it is really difficult. There's data showing 40% of the minority children attend recommended follow-up with primary care. So pushing the daily maintenance ICS has hit a wall for a long time, and we've been looking for alternative option that meets patients' preference and goals. And what happens with not taking daily medication is that many patients ended up taking the SABA only and rely on it, which is really not a good thing to do. So there, some of the recent admin data has shown really the SABA use is widespread. In the US, 52% of all asthma patients are only using asthma. So if you think about it, 50% asthma patients are only SABA users. And then, but within that 62% actually had one exacerbation per year. So which means that there's a pretty good proportion of them probably should not be only taking SABA. And then if you look at the filling record, 72% filled more than 2 or more SABA per year. Globally, same thing is happening, about 40%. This is actually a pretty big number too, was prescribed 3 or more SABA per year. So 3 or more SABA per year is basically considered to be poor symptom control, which is about 40% of the global study from Sabrina too. SABA overuse is associated with poor outcome. It's been shown in many different ways. I just showed one of it here for asthma exacerbation, but it's also shown for all-cause mortality too. So comparing to 1 to 2 canister prescription per year, there's a linear increase of the risk of asthma, severe asthma exacerbation if you go 3 to 5, 6 to 9, 12, 10 to 12, and 13 and above. Even adjusted for other comorbidities and other factors as well. The part of the reason is that SABA is basically a bronchodilator and it causes symptomatic relief, but it doesn't treat the underlying airway inflammation. And there's some data showing there's also adverse events with regular use, increase in eosinophilic inflammation, rebound bronchoconstriction, and loss of bronchoprotection. So just to orient you for what we're going to talk about here, there are different types of non-regular ICS treatment for asthma. So for mild asthma, we call it AIR now, which I kind of like. This is from GINA too, but anti-inflammatory reliever therapy without the maintenance dose. So it's going to go in a little bit more detail here. Either you can do as needed ICS with SABA, or you can do as needed ICS with short onset LABA. And then for the moderate to severe asthma, you can do the single inhalers therapy with ICS formoterol with the maintenance daily dose, which is commonly called as SMART therapy. So what are the potential benefits? We already mentioned about the limitation for taking daily ICS. So there are benefits from as needed use of the inhaled corticosteroid, either with the maintenance or without the maintenance. So if you do it as needed way, the ICS dose follow the disease activity. So the anti-inflammatory component of the ICS will be increased when the disease are presumably active when you have more symptoms. It's a patient-centered way, allowing the patient to control their medication uses, and the data has also been shown higher sense of self-management by the patient. Then also it doesn't require as frequent visit to the doctor adjusting the dose. And for as needed uses without the maintenance, there's been shown to basically show similar outcome with less overall ICS dose and side effects. So so we're going to talk about a little bit about mild asthma treatment. So AIR, anti-inflammatory reliever use, is the concept of this is that you would take the anti-inflammation medication, which is the inhaled corticosteroid, to treat the airway inflammation, and then the reliever medication, which is the bronchodilator, at the same time, either by using 1 inhaler or 2 inhaler. Hopefully, in the future, it'll be 1 to make it all easier, but basically together instead of doing this daily and then this as needed. When we look into in a different way, instead of taking same dose every day, in AIR only sort of a use, this is only as needed only use here I'm showing here, is that you would take the ICS and the reliever inhaler at the same time in different dose on a daily basis. So here, maybe you took 2 puffs, next day you did okay, so none. Is a bad day here that you needed to do more, but then there's a good day here too. So they're going to be a valuable dose per day, or there are going to be some days that you're going to take a lot with the flare as well too, but the dose is not fixed every day. Terminology, I think it's been used a little bit more as needed is used more now, and then GINA is trying to push the AIR here. But if you were to do a lit search, many different terms has been used, PRN, on-demand, rescue, symptom-driven, intermittent, but it's basically means the same thing. Especially for mild asthma, it's quite important way of taking this. The inhaled corticosteroid and a bronchodilator. And we talked about in the earlier part of the talk that mild asthma consists majority of patients with asthma, but then they could still have poor outcome. 37% with acute asthma, 16% of near fatal asthma, 15% the mortality from asthma actually. These patients only had less than weekly symptoms in previous 3 months, indicating that mild asthma patient can have very poor outcome. And even they maybe have infrequent exacerbation. The infrequent is defined. It's to debate what infrequent means. But let's say if you have only once a year exacerbation, it's still the cumulative side effects of the PO steroid will be there because it's a lifelong disease that patient will have to deal with for the rest of their life. But then, especially in mild asthma, difficult to enforce daily ICS because the symptoms are not severe and episodic. But we have more data available now for air and mild asthma. Landmark changes made in GINA 2019, and then in the US guideline in 2020, this also has been added as well. So there's two options here that we can talk about at this point, which is the ICS formoterol, short-acting, long-acting, short onset, long-acting muscarinic. Oh, it should be LABA here, sorry. There's a typo here, short onset LABA is as needed, having symptoms. And there's been a large studies in the past 5 years. It's in the GINA, but it's not included in the US guideline 2020 update because it's not because they're not supporting it, it's because of the cutoff of the data that they reviewed. It's actually not there at the moment. And this is mainly done by the budesonide formoterol, Symbicort, or Symbicort generic, or you can do with Dulera, which we'll talk about a little bit more, or with one inhaler, or you could do with 2 inhalers. This is less popular, but what we have data, which I'm going to review a little bit as well too. So you can use the ICS with SABA when having symptoms, and this is actually in the 2020 update of our own US guideline. So the budesonide formoterol formulation has a lot of data, over 10,000, or at this point, there's more. There's 4 big trials, slightly different, all of them, but it's done and showed good evidence. So compared to a short-acting beta agonist, the exacerbation reduction is about 60%. If you compared to daily dose ICS as needed SABA, these severe exacerbations are either similar or better from sigma 1 and 2 and Novoson and practical with lower dose of ICS use, about 20 to 50% of daily ICS. The symptoms, lung function, airway inflammation, if we look at the large trial, there has been some statistically significant but non-clinical difference, but the difference for these are not clinically significant difference that happens with it, taken as needed. So there's strong data supporting the as needed use with budesonide formoterol. Also good for exercise-induced asthma as well too. So if you compare with just taking the SABA, if you actually take the budesonide formoterol, the dip of the FEV1 change after 6 weeks of use of budesonide formoterol, it actually works as well as taking the daily therapy. So a little bit about this 2 inhaler option here, because it is in the guideline. It's one of the confusing things that it is there. so this is basically using inhaled corticosteroid and then SABA, 2 inhalers at the same time. So there's actually a good evidence for this, but all of the studies is done in beclomethasone and in SABA. So so basically Q-bar plus albuterol or salbutamol. And studies compared to those Sigma studies or other ones, Sigma or practical studies, the studies are not as big, so therefore the evidence are not that strong, but all studies are done independent of pharma. I forgot to mention all of those studies for the budesonide formoterol studies, except for one, is actually funded by AstraZeneca, who is the maker of the Symbicort. And then, except for one study, separate inhalers, so beclomethasone plus IC has been used, but we have children data from Trexa in ASIST. This is our own study that we did, a pragmatic study. And then in adults, we have the PUPPY and BASALT study, which is all showing similar asthma control exacerbation compared to daily therapy with less ICS dose. So I just got to mention about one of our studies that we did this comes to about 5 years ago or so at this point now. It's called ASIST. This is actually the only pragmatic study that was done in ICS plus SABA in the US with partnering with providers in St. Louis. We basically tested the beclomethasone plus using the albuterol and beclomethasone at the same time in 206 African American children taking care of the primary care pediatricians, and essentially have the pediatricians implement the study arm. It was open label studies, and then if you can see, if you look at the asthma control at 6 months, it's no difference on both arms compared to the daily therapy, and then exacerbation as well too. So no surprise that is no different. But what's also good about it is that compared to the dose that the daily ICS group, the AIR group took about 25% of the dose. So the same outcome was achieved in 25% of the dose of the dose exposure for inhaled corticosteroid. And what was also even better about it was that many patients and the family reported higher sense of self-management. So this was from our study data, but 72% of as-needed group thought that they were managing their own asthma versus 44% in a daily group. And then on the for the as-needed ICS formoterol, there also have been multiple studies saying that the people who does the as-needed formoterol ICS, they are more preferring that over daily. So just again, orient you about where in the GINA guideline. I keep showing this because it's really confusing here, but the as needed formoterol ICS is here for step 1, step 2 as a track 1 preferred method here. And then the taking ICS SABA together is on step 1 here for track 2. And also, I'm not showing the NAPP guideline here, but it's on also in an NPP guideline too. So just a little bit about moderate severe asthma here too. I hope we still have time here just to talk about here. About 15 minutes. Okay. All right. So about SMART therapy, just to orient you about SMART is that how the SMART works is that the main difference from the as needed, there's a maintenance. So the M is the maintenance here, the single maintenance and the reliever. So this red is supposed to show the maintenance dose here, but the maintenance dose goes every day. And then you would have the reliever added on top of it, which gets done by a same inhaler. So the beauty for this is that essentially you don't have to have 2 different inhalers. It will get done by ICS formoterol. 1 inhaler is basically the convenience factor that is the big the advantage for this regimen, and the and the added dose that's that is added with following the disease activity. So there's strong data for this. I would have to say many studies. This is actually not really new data because people has been starting looking at smart therapy for a long time. But a couple of points here is that all studies done in budesonide formoterol formulation, and but there's strong evidence from small kids to adults. And if you look at the meta-analysis here, this is more recent one in over 22,000 patients. But if you compare with the same dose of daily ICS LABA plus SABA or higher dose, it still prefers the smart therapy. Does better for risk reduction for exacerbation, about 30 to 40% here. And it is a preferred therapy for step 3 to step 5. That's already been showing you that. And it is also in our national NAPP guideline in 2020 for preferred therapy for step 3 and step 4. So again, now here, this is like I've been showing this many times, so hopefully I orient you with the guideline here, which is at this point, but this is here as well. Just to not to confuse you more for all of this, but a few words about as needed ICS SABA reliever, because this is also now available in the market, which is very exciting because more option is better. But now we do have this budesonide albuterol combo medication in one inhaler called Air Supra from AstraZeneca, now available in the market. They have coupons right now, but that they cover the cost here. But I just looked at the GoodRx, and the GoodRx is showing $400. So we'll see how much it's going to be when they actually get more disseminated more. But this is based on a Mandela trial that was published in 2022. Done in over 3,000 patients funded by AstraZeneca for 3 and 5 step 5 patients. So this is not only as needed use, but basically use the ICS SABA combo instead of using just albuterol. So basically the study was either you do the combo medication low dose, which one is low dose? Low dose or high dose, or just albuterol only. That's added into your usual regimen. So you could be taking, your Brio or your other medications, Advil or other medications, and then they add on the reliever on top of it and see what happens. So what happened is that the higher dosing, which is the blue one here, compared to albuterol only, had a risk reduction for the probability of severe exacerbations about 20% or so. So this is for more 3 to 5 patients, but then also study in mild asthma for as needed only uses a big study over 25,000, but Tula study is ongoing, and we will know about it in 2025. So now in the future, it's going to talk a little bit about the research gap and then implemented challenge and the close up here too. So the research gaps for mild asthma, no children data for as needed ICS formoterol use. So we have a recommendation for over 12, but we don't have that for smaller kiddies. And then we don't really know which patient to use as needed ICS, which patient to keep it daily ICS. There's the subgroup analysis actually is not showing any particular group, so we don't know which one to keep it or which one to change, other than patient preference and the cost and the insurance coverage and things like that too. There's no studies that compared ICS formoterol plus ICS SABA head-to-head on mild asthma. And then also there's no trial basically showing either SMART versus daily ICS plus ICS SABA as needed. It's not been done as well. And then we really don't know is that, I showed the GINA guideline multiple times. That looks like a step up there, but we really don't know like when to step up from as needed ICS to SMART, when will be the best time, if they're started to use it every day, or should we actually keep it as needed base, or should we add the daily, how to best step up or as needed only to SMART, we actually still not really sure. So I'm just going to skip this slide because we're running out of time here. So just to touch about implementation challenges, the clinicians, we talked about budesonide formoterol, but can do it with Dulera theoretically, which is the mometasone formoterol. The dosage instruction for 12 and above is you use the ICS 160 as needed only. Take one inhalation as needed, repeat in a few minutes. If not effective, in a maximum of 12 a day, and then a SMART therapy can add on to 1 pot twice a day. Could do it with lower dose, but there's no study for that too. And then shared decision-making has to happen. Challenges, I'm sure some of you guys said you have tried it, but can't do it constantly, have experienced that because the regimen is not FDA approved because it was done in a different inhaler, the powder form, and it's probably may not be ever FDA approved, but we'll see how that goes there too. And then there's insurance coverage issue with the medication. The cost of the inhalers are always a problem. The budesonide formoterol, it actually came down with the generic out there now, but it is still pretty significant compared to the albuterol, which is $50 or so. We'd have to explain the patient how to do it. There's under perceiver, over perceiver for the symptoms. And then there's a huge thing about patients SABA reliant. So you're going to say, well, you're not going to take the albuterol and use the budesonide formoterol, but a lot of people don't want to give up the albuterol. And then what to do with the nebulizer is also a big thing too, because a lot of people use a nebulizer, albuterol nebulizer. So just wanted to talk about what we actually do in here. We are doing an Air4U pilot study that we are developing. We actually develop all of this, the implementation tool with the air asthma plan, the QR codes for the takes to the video, patient selection sheet, provider information packet for Epic Note template to help the providers like yourself to do air in your practice, especially focus on the primary care physicians who takes care of the mild population. And then we're actually in the middle of pilot testing in 3 community provider sites in St. Louis. And then we have some scale-up planning going on if this is successful. And this is to be presented at ATS 2024. We have air asthma plan. I have a QR code there that you can actually go that we developed for this as well too. If anybody interested, I can send it to this. It's still a work in progress. We're piloting this, but basically talk about how to do the air plan. That this is a action plan-ish sort of an instruction sheet that we made with stakeholders. So just finishing up with the case one, this was a more poorly controlled type patient, symptoms every day, having asthma attacks. What would we do with this patient? And then more milder patients with a couple of times a week symptoms. What would you do? You can kind of comment on the chat, and I'm just going to close it out with a take-home messages about systematic assessment and comorbidity treatment for difficult-to-treat asthma patient is important. Guidelines are complicated, but the bottom line is we do have a lot of data about air and SMART. These are treatment options, so shared decision-making is quite important, but there are good reasons for change and lots of implementations, but we've been making small steps. And so thank you.